I have four main objectives. I'm going to describe the relationship between chronic pain, depression, and insomnia. And then I'm going to discuss some recent data evaluating how inflammation may be a shared mechanism by which sleep disruption increases risk for chronic pain and depression. And then I'm going to briefly highlight cognitive behavior therapy for insomnia as an adjunctive treatment for pain and depression. And then I'm just going to discuss some future directions. So just by way of overview, this slide is published in JAMA quite a while ago, but it illustrates the top 5 diseases that are associated with years lived with disability. And if you can look at the top 5, and this is in the world, low back pain is number 1, musculoskeletal pain is number 2, depression is number 2, and anxiety. So anxiety, depression, and pain round out the top 5. So this is a huge problem. So what is chronic pain? Kind of from an epidemiologic perspective, it's just pain that's gone on for 3 months or more. The International Association for Pain describes 3 types of chronic pain. First one being nociceptive pain, which is related to tissue damage and inflammation, and then neuropathic pain related to nerve damage. And they've recently come up with a new category called nociplastic pain just in the last 5 years. And nociplastic pain is believed to be a centrally driven pain that can't be fully explained by nociceptive or neuropathic pain. And sort of clinically, it usually presents with, rather than a discrete distribution, but more of a regional or a widespread distribution. It's associated with hyperalgesia, and often the symptoms seem to be kind of disproportionate to the degree of tissue damage, if there is tissue damage. And so I mentioned it's thought to be driven by central sensitization, which is a really important construct in the chronic pain world. And central sensitization, this is a slide just showing the classic spinal thalamic pathways that regulate pain. And the key for central sensitization is this idea that pain is modulated by various top-down processes at different levels of the neuroaxis, ranging from the prefrontal cortex down into the midbrain and ultimately spinal cord. And so there are these circuits that descend down from the periaqueductal gray, which is an opioidergic center, and then it goes into the rostral ventral medulla, which then descends into the dorsal horn of the spine and actually gates the amount of afferent signals that get up into the thalamus and then are distributed throughout the pain neuromatrix. And so we believe that central sensitization is a disruption and a pain amplification of the signal, and you can have disruption at multiple levels of the neuroaxis, all the way up from the frontal lobes, the amygdala, down to the PAG and the medulla, and ultimately sensitization in the spinal cord. Talking about chronic pain and depression, I think we all know here that they're very highly comorbid. There's a recent data, a national health interview survey, 31,000 U.S. adults, and reported the rate of chronic pain in the general population being around 21%, depression around 8%. And in this same study, they found the co-prevalence. If you have chronic pain, your chances of having depression are around 24%. And on the other hand, if you were diagnosed with depression or had depression severity symptoms in this survey, 56% chance of also having chronic pain. So highly comorbid. The other thing about this study that I think was really important is that they show that having chronic pain, that the effects on disability and daytime functioning are compounded. So if you have chronic pain and depression, you have greater disability that is additive, and in some cases possibly synergistic. So in terms of, there's a lot of prospective studies out there, and so I just try to call some of the recent meta-analyses, but several studies showing that chronic pain predicts incident development of depression with a hazard ratio of around 1.3, which doesn't sound like a huge amount. Depression, on the other hand, predicts incident low back pain with a hazard ratio of 1.69. So the thinking really is that these disorders are reciprocal. The other point to make is that patients that have chronic pain who are depressed have much worse prognosis, and these are from longitudinal studies. So they have worse pain over time, greater disability, and longer recovery time from the pain. So really important to target these two conditions. And that's sort of the latest thinking, is that you really need to co-treat depression and pain and target them. But you'd be surprised, there are not a lot of studies out there that have sought to do that, look at patients that are diagnosed with MDD or major depression and have chronic pain, and then try to develop a co-treatment strategy. And so there is one study that I think is illustrative called the SCAMP study, and it was in primary care, I think in the VA. Cronke published in JAMA. This is an old study, 2009. 76% of the sample actually met diagnostic criteria for MDD, and the others had at least moderate severity of depression. And patients were randomized to either usual care and basically primary care, where they were allowed to have any kind of medications that the primary care thought were necessary for pain and depression. And then they were put into an algorithmic kind of high-intensity intervention with a mental health professional physician who prescribed 12 weeks of antidepressant optimization and any antidepressant that they felt was important. So 12 weeks of that, followed by 6 weeks of CBT for pain. So pretty intensive. There was also a 6-month relapse prevention phase where they had multiple visits. They had 5 additional in-person visits, 8 telephone visits. So very intensive intervention. And not surprisingly, this combined specialty mental health treatment that targeted both pain and depression resoundingly beat treatment as usual, which doesn't surprise you that much. I mean, there's nice separation there. But when you look at the overall treatment response, it's actually, something's lacking. So one of their main primary endpoints was kind of co-reduction of both depression, so a 50% reduction in depression symptoms and a 30% reduction in chronic pain. And so in that intensive treatment arm, only 30% actually met that benchmark. So a lot was left on the table. It was highly significant compared to 10% in treatment as usual. So really important, but something is not quite as good as we would like it to be. And so this is where I think insomnia comes in, I think is really important. So we already talked about the co-prevalence of depression and chronic pain. Well, insomnia is co-prevalent with all of them. And so chronic insomnia is about 10 to 15% of the adult population has chronic insomnia. But at least 50% of patients who are depressed meet criteria for chronic insomnia, and 50 to 88% of chronic pain patients meet criteria for chronic insomnia. So there's a lot of overlap. And I think one other point to make, so there's a recent network meta-analysis of antidepressants for pain. We all know that SNRIs, for example, are indicated for chronic musculoskeletal pain and nociplastic pain in particular. So recent network meta-analysis of 176 randomized controlled trials, 28,000 subjects, looking at the effects of antidepressants, all kinds of antidepressants, on pain, depression, mood, and insomnia. And so what you can see is they rank order with these network meta-analyses. You can rank order and find sort of which ones stand out. And so they picked only antidepressants that had subjects of at least 200 studies or more. And you can see for pain, the effects were small to moderate, and duloxetine was the clear winner, particularly at high doses. The significant mean difference was about 0.37. So, moderate, low moderate effect size. For mood, though, strikingly not very good. The effect sizes were negative 0.16, 0.13 for milnacipran. Mirtazapine, only one study, so it's hard to compare, but those are the top 3 for mood. The thing about these studies were that there's sort of a floor effect. They didn't capture people that had frank depression. For the most part, these were patients that had subclinical depression. And so that's just a huge gap in the literature. We really need to study patients that have both frank diagnosis and chronic pain. The effects on sleep, which I want to highlight, are very small. So the point here being that antidepressants for pain don't work for sleep. And it highlights the need to sort of treat them. So moving more into why I think insomnia is really important. Insomnia is an independent risk factor for major depression and for chronic pain. And these are data by Breslow et al. A long time ago, just showing that in patients that didn't have depression, their rates of developing depression, if they had baseline insomnia over a 3-year period, were fourfold higher of developing new onset depression. When they controlled for a family history of depression, the odds went down to about 2. So twofold. A lot of longitudinal literature out there really showing that insomnia is a major risk factor for new onset and recurrence of major depression. Insomnia attenuates treatment response for depression. It increases the time to remission. And one of the things that we know is that residual insomnia after successful antidepressant therapy is another big risk factor for relapse. So all very strong arguments for treating insomnia. Same kind of thing with chronic pain. So there's at least 5 prospective epidemiologic studies showing that insomnia, and these are pain-free people followed over 1 to 3 years, the odds of developing new onset chronic pain are 2 to 3-fold. And that's controlling for depression. So there's something very significant about insomnia that's not just overlapping with mood disorders and depression. Another study which I thought was really interesting, a longitudinal study by Davies, showing that if you had chronic widespread pain, so fibromyalgia, and you reported good sleep, you had a 3-fold rate of remitting from chronic pain, which is kind of promising. These are studies. This is a study from incident TMD from the OPERA study, partly done over at the University of Maryland. And what this shows is just these are incident cases of TMD. So TMD pain-free individuals. So pain-free individuals, and they looked at those who went on to develop TMD. And what they saw was that after about 6 months before the diagnosis of TMD, chronic TMDs, insomnia started to spike. And so you can see that. And you see the same thing in depression. Before the onset of a major depressive episode, insomnia is often kind of the first prodromal symptom. So big opportunity for prevention, potentially. So a lot of my research has been on, could this be a causal relationship between sleep and pain and sleep and depression? And there are multiple studies dating back from the early 70s showing that multiple forms of sleep loss lead to next-day hyperalgesia or enhanced pain sensitivity. So a lot of studies. Recent work by our lab and others have tried to look at measures of psychophysiologic measures of central sensitization, which capture the tendency of your central nervous system to amplify the pain signal. And so several studies have shown that what happens, experimental sleep loss in healthy people impairs descending pain inhibitory controls, which is an opioidergic, that descending circuit. It's an opioid driven from the PAG down to the rostral-ventral medulla. But it's also modulated by monoamines, that circuit. So serotonin, norepinephrine influence this pain inhibitory capacity, which is called conditioned pain modulation. And so conditioned pain modulation is common. Deficits in pain inhibitory capacity are common in chronic pain disorders like fibromyalgia, back pain, osteoarthritis. And that people who have reduced pain inhibitory capacity go on to develop chronic pain at a much higher rate. So there's a lot of post-surgical studies. So people who have developed chronic post-surgical pain who have impaired CPM at baseline or right after surgery go on to develop chronic pain. Another pain modulatory process that sleep deprivation seems to impair is something called temporal summation, which is, we measure it by presenting a very repeated noxious stimuli at a constant rate of about interstimulus interval of about 1.5 seconds. And what it does is it causes the perceptive pain to ratchet up in a wind-up fashion. And that's driven by NMDA receptors in the dorsal second-order neurons in the dorsal horn of the spine. And so there's several studies, including one by us, showing that females who are sleep deprived have enhanced temporal summation of pain. So those pain facilitatory processes are amplified as well. So it's sort of sleep loss impairs descending pain inhibition and also activates pain facilitatory pathways that are glutamatergic. So similarly, what does experimental sleep loss do for affective functioning? This is a recent meta-analysis by Tommaso published in Sleep. and others, and they asked the question, and these are studies over decades, lots of studies. I don't know what the N is, but it's very large. But what you can see here, the point that I want to make is experimental. We all know that sleep loss impacts mood, but it really particularly hammers positive mood, your ability to feel positive affect, more so than negative mood. The effect size is 0.45 for negative mood. And so I think in some ways that points to this positive affect generating mechanisms in the brain, and I'll talk more about the nucleus accumbens and opioid systems in a bit. Leads to the question, so that's the experimental literature, as well as the longitudinal literature. But we don't really know what are the modifiable mechanisms by which sleep disturbance contributes to clinical nociplastic pain and depression. We don't have a good understanding at all of the molecular factors that are involved, and we don't have any real clear sense of which aspects of sleep architecture drive this phenomenon. A lot of the sleep deprivation studies were 36 hours of total sleep deprivation, so it doesn't say much about which aspects of sleep architecture seem to be hyperalgesic or contribute to impaired mood. And so before we go into the mechanism piece, I just wanted to provide a little bit of an overview. EEG data, just looking at the profile of EEG in depression and chronic pain. And so these are two hypnograms. The top one are depressed, kind of a summary of what a depressed hypnogram looks like. A hypnogram is just EEG recording throughout the night, measuring different sleep architecture stages. And so sleep architecture abnormalities are really common in depression. One of the most common ones is reduced REM latency, so people drop into REM at around, on average, 45 minutes, whereas in a healthy adult would be about 90 minutes. They also have greater REM density, so your eye movements during REM sleep are much more dense in major depression. And the other thing are slow wave deficits. So slow wave sleep is that deep phase of sleep. And what you can see here, I don't know if I can, on the top, you can see that in cycle 1, that gray area of slow wave sleep, the deepest phase of sleep, in depressed patients, they actually get less slow wave sleep in that first cycle. And what's normal is for you to bleed off your homeostatic drive for slow wave sleep in that first cycle. So there's something very dysregulated about depression in terms of the homeostatic process by which slow wave sleep is distributed across the night. So what about chronic pain? What are the EEG signatures of chronic pain? We don't really have great data on that. Recent kind of case-controlled meta-analysis by my colleague Mike Irwin found, what you would expect to find: sleep continuity disruption, so a lot of insomnia, a lot of trouble falling asleep, middle of the night wakenings, a lot of wake after sleep onset time, early morning awakenings. But the sleep architecture finding that kind of came out the most was reduced slow wave sleep. So we've got two slow wave sleep being deficits shown in depression and in chronic pain. And slow wave sleep, as many of us know, is implicated in memory consolidation. Some data suggesting that glymphatic clearance in the brain happens preferentially during slow wave sleep. And it's also really critically related to immune function. All your growth hormone is secreted in slow wave sleep. So it's a really kind of physically restorative dimension of sleep. So moving into mechanisms, one potential candidate mechanism by which insomnia is a risk factor for depression and chronic pain is systemic inflammation. So we know that total and partial sleep deprivation enhances systemic inflammation, both circulating IL-6 levels, TNF-alpha, but also at the cellular and genomic levels. And inflammation sensitizes both peripheral and central nociceptive processes. And neuroinflammation disrupts descending opioidergic pain inhibitory circuits and the pain suppressive effects of opioid drugs. So inflammation, I think, is a really important target, and we know that some forms of depression are associated with elevations in inflammatory processes. So we did an experiment just published last year in 2023. These are healthy controls. It's a within subject study, so people were randomized to two different sleep conditions. And so they had undisturbed sleep for 2 nights in a row, where they slept for 8 hours in the hospital. Then they had 2-week washout, and they had 2 nights of forced awakening paradigm, where we wake people up 8 times a night, 7 times for 20-minute awakenings, and then 1 hour is a full awakening. So they end up getting about 4 hours a night, but their sleep is all chunked up. So we did that, and then we did morning blood draws to assess IL-6 and inflammation, TNF-alpha. And then we did pain testing after the blood draws, about 2 hours after the blood draw. And what I like about the forced awakening paradigm, so unlike total sleep deprivation, you get, it impacts both REM sleep and slow wave sleep, and there's good individual variation in the kind of disruption. So it will allow us to model architectural effects on hyperalgesia and inflammation. So in this study, what we were trying to do is see if forced awakening would induce hyperalgesia, thermal hyperalgesia, and whether that was mediated by an increase in what we call cellular inflammation. So we took blood and isolated peripheral blood mononuclear cells and then stimulated the blood with LPS to measure kind of the cellular inflammatory capacity. So first question was, does sleep disruption increase cellular inflammation? And so in our hands, it did. So these are flow cytometric data. So you can see that the forced awakening condition was associated with greater cellular inflammation, both in terms of IL-6, TNF-alpha, and the cells expressing both TNF-alpha and IL-6. So the next question is, does sleep disruption induce thermal hyperalgesia? So we have a thermal that we put on the arm, and it calibrates, delivers heat stimuli, and when the person first perceives that as painful, then they just say stop, and we get a measure of heat pain threshold. And so we did find that forced awakening compared to the normal sleep condition caused thermal hyperalgesia. And so the next question is, does sleep architecture matter? And so we hypothesized that slow wave sleep would be a driver of inflammation, which would in turn be related to thermal hyperalgesia. So we interrogated models with slow wave sleep, but also with REM sleep, total sleep time, and the percentage of N2. So we're trying to figure out which elements of architecture mapped on. So this is sort of the double mediation model that we proposed. So you can see that sleep condition leading to slow wave sleep, leading to intracellular cytokine expression and the stimulated cytokines, and then in turn causing hyperalgesia, which is in fact what we wound up finding. So it was very rewarding to kind of have a hypothesis and have it actually bear out. So that's more of a human kind of analog study that's in healthy subjects. So we just completed a study with my colleague Mike Irwin at UCLA, and this study was in older adults that half of them had insomnia, half of them were good sleeper controls. Average age was, I think, 66. 160 older adults, 2/3 of them were controls and the other third was insomniacs. Mean age is 66. They had no chronic pain or depression, but you know, we had an insomnia cohort and a normal sleeper. And so the first question was, and so what we did was we administered endotoxin, which is sort of like an inert cell wall that causes an inflammatory reaction. It causes like a sickness behavior. So these people were obviously in the hospital and screened for, you know, being very healthy other than having insomnia. And so we injected endotoxin in the morning, and then we did serial blood draws throughout the 8-hour day. And then we had mood ratings just about every hour, and they had affective tasks, which I'm not going to talk about today, but we also did quantitative sensory testing, pain testing, which didn't happen until about 5.5 hours after the injection, so it happened in the later part of the afternoon. And so first question was, is insomnia related to the inflammatory reaction to endotoxin? And we hypothesized that patients with insomnia would have a hyper-exaggerated response to the endotoxin. And we didn't find that. What we did find was there was a massive endotoxin response, and both insomniacs and healthy controls had a similar reaction. There's a little bit of tendency to have the insomniacs have a slight increase in inflammatory response, but I think it was in some ways it's a blunt metric. It just sort of hammers the immune system and causes this big massive reaction, and so there isn't a lot of, I think it was just too much. So we did have a big inflammatory reaction. This is IL-6, but we had the same kind of thing for all the other pro-inflammatory cytokines like TNF-alpha, etc. So these are the data on mood, though, which I think is really interesting. So these are the profile of mood states. We're just asking people to report their mood, and this is depressed mood. And so you can see that the insomniacs who got endotoxin had a massive increase in depressed mood, whereas the healthy older adults had almost no reaction. They had a little bit of an increase, like at 1.5 hours, but then after that they went back to normal. So what about the effects on pain sensitivity? One of the measures that we did was pressure pain threshold. We measured it at the masseter muscle, the trapezius, and then the quadriceps. And these are data, it's a Z-score data, so low means more pain sensitivity. So you can see that the insomniacs had a heightened degree of pressure pain sensitivity that got endotoxin, whereas the controls did not. So we see both an inflammatory reaction that induces pressure, hyperalgesia, and mood disturbance, depressed mood disturbance in this group. So this is sort of the working model that we have in terms of the neurobiology of what we think is going on. So we're really starting to focus in on the mesolimbic system. And there's a lot of overlap between mood, depression, and pain and sleep in the mesolimbic system. And the nucleus accumbens in particular seems to be an important area. Nora Volkow at NIDA has some sleep deprivation studies showing that sleep deprivation causes a dopamine receptor, D2 dopamine receptor downregulation in the nucleus accumbens in particular. And this nucleus accumbens connects to the PAG, that descending pain inhibitory circuit that we already showed was impaired by sleep loss. So what we think is going on is that there's sleep loss causes an inflammatory dysregulation, which interacts with these descending pain modulatory networks, which increases risk for chronic pain and depression. That's sort of the model that we're working on. Treatment is important, and you can't get this from a book because there's a huge move right now in healthcare to digitize everything and have robots do stuff. And so, these problems are really intractable, very difficult, and the relationship is always the most important thing, I think, in many respects. So it's so good to hear you say that, and I agree with you 100%. So I just give you a little bit of background on CBT. It really is this first-line treatment now. It used to, it started in NIH in 2005. They started recognizing that CBT was really efficacious. But the American College of Physicians back in 2016 listed it as sort of the first-line treatment for chronic insomnia disorder, mainly because of several meta-analyses and multiple studies all showing that the effects of CBTI are comparable to pharmacotherapies. And the side effects are much less, and the results are much longer lasting. So they usually go out to a couple of years, or as long as you can measure it. So CBTI, like we already heard, is really a multi-component intervention. And what I want to stress is that it doesn't overlap with CBT for pain or CBT for depression. So it's very distinct. The two kind of major treatment components are stimulus control therapy and sleep restriction therapy. Those have the overwhelming empirical evidence. But then there are other components like sleep hygiene, for example, which is what most people think about when they think of CBT for insomnia. But sleep hygiene really is getting it in a book and saying you should do this, and that's been shown over and over again that it doesn't work. In fact, we use sleep hygiene as our comparator control condition to see if we can beat it. And then other components like relaxation therapy. I think you found that relaxation therapy was helpful. That can be really important. Usually the effect sizes for relaxation therapy are not quite as robust as stimulus control and sleep restriction. There's a cognitive therapy piece to it, focusing on pre-sleep cognitions. And then some people do bright light therapy as another piece, and we're exploring that in the context of depression and pain right now. So I can't go into all the details around it, but I did want to just sort of summarize the meta-analytic work. So the big question for me was, or for many of the providers, is does CBTI work in patients that have major depression? And then if it does work, is it antidepressant? I spent all this time talking about the longitudinal relationships. So does pure CBTI that has no kind of other ingredients related to antidepressant, no CBTI, no CBT for depression elements, does it actually improve mood? And so recent meta-analysis just published in 2024, 19 RCTs, 4,800 patients. The effect sizes for insomnia remission were pretty large. The odds ratio was 3.57. So CBTI beats the control, the sleep hygiene education, by a lot. And then what about the depression data? And these are the results. And so moderate to large effect sizes on depression reduction in major depression. Now this meta-analysis did depression response and insomnia remission as the endpoints. So you can see that there's a lot of room to be had here. So CBTI, if you got CBTI, you had a 32% chance of remitting or having a 50% reduction in depression versus 17% in the control. And then for insomnia remission, so people who completely remitted, 26% versus 8%. So these aren't great percentages. Like, these treatments are good, but they're not solving all the problem. There's a lot of work that we need to do, even though these are really large effect sizes. So what about for chronic pain? So recent meta-analysis in 2021 summarizing, I think about more than seven actually. We'll see how many studies it is. I don't have the number there. But you can see at least, say 12, 15 studies. The effect size of CBTI on insomnia in chronic pain patients is large, 0.89 effect size. There is an attenuation at follow-up. It goes down to a moderate effect size at follow-up treatment. But the probability of having better sleep at post-treatment was 81% and 71% at follow-up. So good for sleep. Does it improve pain? Small, significant but small effect size, 0.2, not great, but that effect size is actually comparable to the effect sizes of CBT for pain. Pain is an intractable symptom that's very hard. The effect size goes up if you look at pain-related disability or interference. Then it goes up to more of like a moderate effect size. But in terms of purely improving pain severity ratings, we have a lot of work to do. So future directions, our lab is working on trying to find ways to optimize CBT for both pain and depression. We were just doing kind of out-of-the-box CBT for insomnia, but I think there's a lot of adaptations that you need to make with patients that have pain and or depression. We need to have mechanistic adaptive designs to test components and the sequences of those components. Normally we just kind of throw everything in the book at them, and I think we can overwhelm patients. And if we really knew, which component was important for which type of patient, and so that's really got to be done. Novel hybrids combining CBTI with CBT for pain, maybe with bright light treatment. There's some really interesting studies showing that bright light therapy in the blue to green spectrum has analgesic properties. A lot of animal work showing that. And we know that bright light treatments for morning bright light treatment for depression is quite effective as well. So we have a study through National Institute on Aging to look at combining CBTI with bright light treatment in patients before they undergo knee replacement surgery. We need to continue the mechanistic studies so we can try to figure out which aspects of sleep drive hyperalgesia and negative mood. We have a PET mu-opioid receptor imaging carfentanil PET study going on. This will just be ending in a year, looking at the effects of different types of sleep disruption on mu-opioid receptor binding when the patient's in pain or not in pain, that I think will be really informative. And we need to test newer sedative hypnotics for depression. There's some newer classes of medications, the DORAs, the dual orexin receptor antagonists. Andrew Hune is doing a lot of work in substance abuse patients, finding this medication to be very helpful. And I think it's got lots of implications for depression and chronic pain as well. The abuse liability profile is much better. It's well tolerated in older adults. So I think there's a lot of opportunity there. And then I think we need to develop sleep-related biomarkers that predict treatment response, both for depression and for pain. And so future directions, I mean, in my lifetime, we used to measure sleep like this in the lab with paper. The pens, they had these like polygraphs that would actually, write out the EEG waveforms on paper, and it would just, every piece of paper was a 30-second epoch, and it would just stack up the entire night, and then you'd have to read this whole thing. But now everything's being condensed into wireless EEG devices, and that's really going to just be a huge game changer for developing biomarkers and for developing sleep-related interventions in real time in vivo. And so this is a picture of one of the devices that we're using. This is our friend Curzio. But it's just like a wireless little patch that you can put on your forehead, and we can reasonably score sleep. We have AI algorithms that can do it on the fly and score sleep as well as a human. And so this is just huge, because we can give this to someone and have them wear it for 3 weeks at a time and get detailed information about what's going on in their brain all night long. One emerging kind of paradigm that I think is illustrative of where things might go in terms of mechanistic focus. There's something called acoustic stimulation during slow wave sleep, and it's an emerging new treatment. It's developed in like 2013, but the idea behind it is it was initially done with regular in-hospital PSG, but it can be done now with wireless EEG. So you monitor brain activity in real time, and when the brain drops into slow wave sleep, you just deliver a burst, an automated burst of pink noise, which is kind of like a white noise, 50 milliseconds, very, very brief, right at the kind of up state of the wave. And that actually causes an increase in the amplitude of the slow wave, and then you have another one that paces it, and you can entrain it so that you actually can increase the amount of slow wave activity using this acoustic stimulation. It doesn't wake you up, it's very brief, it doesn't register in terms of an arousal. But what's amazing about this phenomena is that it has physiologic effects. So in young adults, it improves memory consolidation, it alters the immune system milieu. All the things that we know are related to slow wave sleep seem to be enhanced by acoustic stimulation. It actually can increase heart rate variability, so it can modulate the autonomic nervous system. The problem with acoustic stimulation is that it doesn't work in unfortunately it doesn't work in older adults, which is one of the populations that needs to benefit the most from slow wave sleep enhancement, because slow wave sleep declines in older age. So Matthew Reed and I and our colleagues at the Applied Physics Lab are working on a project that we call it's called Sounds Cool, and it's combining acoustic stimulation with a proprietary device that they've developed, so a wireless EEG device that's sort of monitoring EEG in real time and then able to stimulate acoustically. But we're combining it with active thermal modulation. So we have a mattress that's cooled by water, and it can cool down and go down to a desired temperature. And it's hooked into the EEG as well. So when you fall asleep, it shoots the temperature down, and we know that when you reduce your core body temperature, that enhances slow wave activity. And so we think that by combining thermal regulation with acoustic stimulation, we can get a nice effect in older adults. And so we're working on that now. I won't go into the details of how this all works, but this is the picture of the device as we have it now. It's the mattress and the waveform that he's wearing. And so I'll end there and leave it open for some questions, but I just want to thank everyone in our lab. And if I left people off, this is an old slide, so I apologize to all the postdocs who I might have left off. But thank you very much, and I think we have a couple minutes for questions. So.
Thanks, Dr. Smith. You mentioned personalized medicine towards the end there, and the thing I wanted to ask you about is are there any indications about who might be most appropriate for CBTI and who might be most appropriate for a pharmacologic sleep intervention?
Yes. So there's a phenotype called the insomniac with objective short sleep. So if you have insomnia symptoms, it doesn't mean you necessarily have sleep loss, but there's a subgroup of patients with insomnia that do have objective short sleep. So if you get less than 6.5 hours on EEG sleep on one night, you're considered a short sleeper. And that phenotype is associated with 5-fold rate of hypertension, all sorts of cardiometabolic problems. It's a very severe phenotype. CBTI doesn't work quite as well. It works in this phenotype, but there's about a 30% reduction in efficacy with this phenotype. And so we think that medications might be important for this phenotype. The other kind of biomarker that we're really interested in is something called the delta ratio, which is the idea that in depression, you're supposed to have all your slow wave sleep discharge, or most of it discharged in the first cycle compared to the second, so there's a reduction in slow wave over time. In some patients with depression, that's flipped, and they actually don't have as much of a reduction of slow wave sleep in the first cycle. And so there's a couple of studies suggesting that phenotype predicts the response to antidepressant response to ketamine. And so we're kind of playing around with that. Now that we can do wireless EEG, this could be a phenotype that we could get in the doctor's office, in the primary care physician, and that might be really informative. So we think that delta ratio may, if you combined, say, ketamine with a sleep intervention, we might be able to prolong the antidepressant effect. It's just a hypothesis, but those are the kinds of things in terms of where we're going with stuff.
Interesting. Questions? We have time for maybe one. Dr. Morrow gets to ask the one. Go ahead. Better be good.
Right. You're asking a sleep guy, so I would say yes.
So just to repeat for everybody, should we be getting sleep studies on everyone with depression?
Should they be?
Isn't that what you asked?
So, so rates of sleep apnea, so sleep studies are really good at sort of diagnosing and ruling out. So insomnia in some respects is a rule-out diagnosis. So you do have to make sure that you're ruling out sleep apnea, periodic limb movements, and PSG is really the only way to do that. But I would say that there are home sleep tests now that we do regularly that are very unobtrusive, and we do them at Hopkins. And so, if your patient is overweight and has chronic pain or depression, and they're complaining of daytime sleepiness, not fatigue, but daytime sleepiness, definitely get a sleep study, because I think it could, the overlapping rates, in chronic pain, the rates of sleep apnea are like 20 to 30%, so very, very prevalent. So I would highly recommend it. We don't, unfortunately, all this stuff about biomarkers, that's all research right now, but I think that will change in the next 5 to 10 years. So.
All right. Thanks, everybody. Thank you, Dr. Smith.